Okay, this is Dr. D. We're going to go ahead and continue threats to elimination in the child. We just finished up the GI system, so now we're going to do the GU system, which is urinary tract infections, nephrotic syndrome, acute post-streptococcal glomerulonephritis, and Wilms tumor. So, UTIs. About 80% of UTIs come from E. coli or some other gram-negative bacteria. It's often, other times it's often because of anatomic or physical factors. Stasis is the single most important host factor. Because what happens is when urine just sits there, that's when E. coli can build up and cause that infection. And the stasis could be primary, meaning it comes from some kind of anatomic defect, or secondary, meaning they acquired stasis. It could be from reflux. So normally urine comes from the kidneys down the ureters to the bladder, and then the bladder to the urethra out. Reflux is where urine comes from the bladder and kind of creeps up the ureters back to the kidney. It's a retrograde flow of urine. And there can be altered urine or bladder chemistries. Organisms like an alkalotic state, and urine is normally acidic, so that's why we like to keep urine on the acidic side so that organisms can't build up. Peak incidence is normally about 2 to 6 years of age, and UTIs can be acute, meaning they just, happen one time, or chronic and they're reoccurring. Risk factors, again, stasis is the single most important factor. Females tend to be at higher risk because their urethra is shorter. It takes less time for the organism to come from the skin and travel up the urethra to the bladder. Males, they say that circumcisions decrease the incidence of UTIs, but it's not significant enough that we would encourage circumcisions. Anytime there's incomplete emptying of the bladder or the bladder is over distended and urine again sits. Sexual abuse or any sexual activity increases the risk of UTI. Bubble bath. If the child is wiping wrong, so if they're wiping from the anus to the urethra, or if they have any abnormalities in the structure, so any anatomic abnormalities. So clinical manifestations are normally separated by lower and upper. So when we talk about the lower tract, we're talking about, you can see right here, we're talking about the urethra, the bladder right here, and there is no systemic symptoms typically with a lower tract infection. When we talk about upper tract, now we're going to involve the ureters, the renal parenchyma, the pelvis, and with that they get those systemic symptoms. So lower, they will complain of frequency, meaning that they have to go to the bathroom all the time. Dysuria, painful urine. A lot of times parents will say that the child cries or holds themselves when they have to, go to the bathroom. Urgency is the sudden, sense that I need to go to the bathroom and I need to go right now. Enuresis is bedwetting. So you might have a child who is 5 years old that has been potty trained for 2 years suddenly start wetting the bed at night. They can have a strong smelling urine. They become incontinent. Sometimes decreased appetite or abdominal back pain, but not as much with the lower infections. Upper, again, we said those are systemic. So you're going to see a fever, chills, abdominal pain, flank pain, and they will have persistent vomiting because they're sick. It's kind of attacking their whole system. And because of that, they can develop dehydration, either moderate dehydration or even severe dehydration. Now we have those subsets. Infants, obviously they can't talk to us. They can't tell us it burns. They don't have bladder control, so we're not expecting to see it. So we'll see things like poor feeding or that they're more irritable. And when we talk about older adults, a lot of times older adults, the only symptom they present with is confusion. They might have some slight abdominal distension, but oftentimes they present with confusion. So if we suspect a UTI, we're going to get some diagnostic tests to rule it out. And obviously clinical manifestations help make the diagnosis. And our UA is going to have an increased number of white blood cells. So normally there's 0 to 5 white blood cells in the urine, and with a UTI we're going to see, greater than 5, greater than 10,000 white blood cells. We're going to get a urine culture and sensitivity. That helps us determine what the organism is. So the best way, the most sterile way to do that is to either cath them or to do a suprapubic tap, which means that they insert a needle through the skin in the suprapubic region and access the bladder directly. Obviously, that's very invasive and not the first line. If we can get a clean catch, that can work for a urine culture and sensitivity. So what we do is we have them go in, we wipe from vagina to anus, and then we tell them to urinate a little bit in the toilet, and then stop, and then urinate the rest in the cup. So that's a clean catch midstream. And oftentimes the best results are in the morning. We might get a KUB, which is kidneys, ureters, bladder. It's an X-ray of the kidneys, ureter, and bladder. We might get a renal ultrasound, which might show us masses. If there's some kind of mass here, it might be blocking urine from coming down, and that's what's causing the stasis and the infection to develop. We can get a VCUG, which is a voiding cystourethrogram. And this is where we fill the bladder with contrast, and we then have them pee the contrast out, and we can take a picture once they voided and see what residual is left. So it's a good way for us to kind of tell, are they able to empty their bladder all the way? Is there any stasis happening? Or an IVP, which is an intravenous pyelogram. And that's, again, contrast is inserted and you can see the function of the kidney. So how do we treat? Antibiotics. Now, we have to be very careful. We do not start antibiotics until we get the culture first. Because if we start antibiotics and then get the culture, then we're not going to get good results. We're not going to know what organism it is we're treating. The most common antibiotics we use are penicillins, such as Augmentin, sulfamides, like Bactrim DS, cephalosporins, like Suprex, or nitrofurantoin. We need to rehydrate because that's going to help, so increase fluids because that's going to help flush out the kidneys and get rid of the organisms. Vitamin C helps to make that urine more acidic so that the organism won't be able to survive. We do things like dried cranberries. So everyone thinks when you have a UTI, you need to drink cranberry juice because cranberry juice is what keeps the urine acidic. But cranberry juice doesn't really make the urine acidic, but it does help prevent bacteria from adhering to the wall of the bladder. So we do like cranberry juice, but not because it keeps it acidic. So because we don't like to give a lot of juice to kids, what we would do is give them dried cranberries, and it has the same effect. We want to encourage frequent voiding. So we want them voiding at least 5 or 6 times a day. Again, that's going to help flush out the organism. We can do antipyretics if they're febrile, Tylenol or ibuprofen. Antispasmodics, so things like pyridium, that helps decrease the irritation and the pain. And it's hard because you can see we're doing several different types of medicine here. So the patient might be confused. So you as the nurse really needs to educate the parent and not just say, here's your pills to treat your UTI, is to say, here's your antibiotic, that treats the infection. Here's your antipyretic, that's going to treat the fever that you have because of the infection. Here's your antispasmodics. They are going to go ahead and treat, some pain and discomfort, but they don't treat the infection because we want them to understand that there's a reason they're taking all these different meds and what they're for. If there is any kind of anatomical defect, we're going to go ahead and do surgery to fix the defect. And we really need to teach really good education for the child and the parents. We need to teach them not to hold their urine, that they need lots of fluids, that there's no bubble baths because it puts them at higher risk, that they need to wear cotton underwear so that the skin has room to breathe, and that they should be wiping front to back. That if it's a baby, an infant, or a child wearing diapers, those diapers need to be changed frequently. That they shouldn't wear tight clothing, and that they should practice abstinence, and if they can't, that they should at least void after sex. They need to avoid constipation because constipation can actually put pressure on the urethra and block urine from getting out. And if they do have something like reflux, they're often put on low-dose antibiotics for an extended period of time to help prevent an infection, and they get urine cultures every 2 to 3 months. Most kids with reflux will outgrow it. Every now and then they have to have surgery to fix that defect. So that's UTIs. All right. So next is nephrotic syndrome. So it is a disorder characterized by increased glomerular permeability to plasma protein. So we see here what a normal glomeruli looks like and all the proteins inside. What happens is that this membrane becomes permeable and all the protein leaks out into the urine and then is excreted with the urine. So you have increased glomerular permeability that results in massive urinary protein loss, which then decreases your serum protein or serum albumin. So there are 2 types of nephrotic syndrome. Minimal change nephrotic syndrome, which is your primary, and your secondary, and then there's a secondary. So primary nephrotic syndrome is that minimal change nephrotic syndrome, MCNS, and it is idiopathic. We don't know why the child has it. The patho is unknown. It's congenital, inherited. It's usually because of some kind of bacterial viral infection, and these the kids who do get it, 2/3 of them will relapse because of an allergy or because of a reaction to an immunization. And they tend to have it for years, but the prognosis is very favorable. This happens in children mostly 2 to 7 years of age, and again, males are more common. Secondary nephrotic syndrome is secondary to a disease. So there's some kind of glomerular damage, and we know the etiology, meaning they took too many NSAIDs or antibiotics or lithium, or there's cancer or leukemia or syphilis or HIV, hepatitis, lymphoma. We know something damaged the kidneys, and that's what's causing nephrotic syndrome. So we're going to focus on the minimal change nephrotic syndrome because it's more related to kids. So because of the decreased serum albumin, it leads to decreased oncotic pressure and increased hepatic synthesis of protein and lipids. This decreased oncotic pressure, and remember, oncotic pressure is the pressure that causes plasma colloids to pull fluid from the tissue to the intravascular space. So that's decreased. So that oncotic pressure is unable to pull the fluid from the tissues. And then kind of in relation to that, there's decreased colloid osmotic pressure in the capillaries. And osmotic pressure is the pressure required to stop osmosis, which is the movement of water from a spot of less H2O to a spot of more H2O. And what's happening is that the vascular hydrostatic pressure, which is that force of fluid within the compartments that moves fluid from intravascular to interstitial, is greater than the pull of the colloidal pressure. So you have all those things that we've talked about in fluid electrolytes happening, but basically we're not pulling fluid into the intravascular space, and it's staying in the interstitial space. So then fluid is going to accumulate in that interstitial space in the body. And because that's all in the tissues, you're going to have decreased vascular volume. So that's going to lead to hypovolemia. And the hypovolemia leads to the increased tubular reabsorption of sodium water, stimulates the RAS system, and there's decreased renal blood flow. So the body doesn't have enough fluid. So it's saying, oh, okay, let's reabsorb sodium and water so that we can go ahead and increase our intravascular volume. So it's trying to compensate here. And at the same time, it's going to stimulate the RAS system because that secretes aldosterone and ADH and secretes renin, which is going to cause vasoconstriction, which is going to help compensate for our lack of volume. So let's look at the clinical manifestations then. Well, massive protein loss. So they have proteinuria. So when you look at a UA, they have 3 plus protein, and there should be no protein. Now, albumin is what we use. It's kind of the building blocks for cells, right? So when we don't have that protein, they get hypoproteinemia, meaning low protein in the serum, and hypoalbuminemia, low album in the serum. And that's going to lead to anorexia. They're going to be malnourished, less active, irritable, pallor, fatigue. They don't feel good. They don't have those building blocks they need to function properly. And because of the increased hepatic synthesis, they're going to have hyperlipidemia. Their lipids are going to be very high. So the fluid accumulates in the interstitial space, so they have edema, and that's generalized edema. Weight gain with that generalized edema, and like we saw in that picture, significant facial edema. And fluid also accumulates in body cavities, especially the abdomen. So they're going to develop that ascites. Now, blood pressure, because there is some vasoconstriction happening, despite the hypovolemia, blood pressure might be normal, maybe slightly decreased. But you're going, because of the secretion of ADH and antidiuretic hormone, meaning antidiuretic is no pee. So they're holding water. And so they're already having edema, and now they're going to have marked edema because they keep retaining fluid. And then if we have decreased renal blood flow to the kidneys, then we're going to have decreased urine output. So we diagnose it. Again, on the UA, you're going to see this massive proteinuria. They have frothy urine. But there's no blood. Okay? No blood. Their H&H is normal to high. And this is just because it's super concentrated. So it's not like you lost any hemoglobin or hematocrit, but you lost volume. I'm sorry, it's not like you gained, it's not like you've increased your hemoglobin or hematocrit, but because you lost volume, it appears as though your H&H are higher. Your platelets will be lower, your sodium is lower. And if we don't get a response to treatment, we'll have to do a renal biopsy to see what's going on so that we can try to help. So therapeutic management, treatment, our goal is to stop the urinary protein loss. This is what's starting it all, right? This loss of massive protein leads to all of this. So the first line of therapy is corticosteroids, like prednisone. And we typically use them for 7 to 21 days. And then we can repeat if the patient relapses. But we have to be careful about side effects because, again, in nursing, we talked about this. We do things to help the patient, but oftentimes the things we do also have their own side effects. And if we're not aware, we can actually make the situation worse. So the patient can have weight gain, a round face, an increase in appetite, growth retardation, hypertension, bone demineralization, infection, hyperglycemia. So those patients with insulin need to be educated, or, educate the parents that, your child may be hungry more, and that's okay. So it's just really important that, yes, we're going to use corticosteroids to treat, but to decrease the inflammation, decrease that permeability, but we need to understand the side effects associated with it. We might start diuretics if there's complications from edema. So if the edema is compromising the airway or anything like that, we give diuretics to help them. Antibiotics are used only as needed, only if there is a known infection. Diet, obviously we want to restrict anything with salt because we don't want to have any more edema related to it, fluid retention, and they're often on fluid restriction. Checking vital signs. So one thing that we're worried about with corticosteroids is the infection. So we look for fever, and we also need to check the daily weights in I&O. So they're on strict I&O. If it's a baby, we'll even put cotton balls in their diaper to catch urine and measure it. We'll get a UA. We'll continue to get UAs because we want to continue to check the protein and the albumin. We're going to measure abdominal girth to check for the ascites, assess for edema, focus on nutrition. Again, the diet, the low salt, fluid restriction, monitor for infection, and provide this child with some recreation or diversional activities because they can't go to school or be out running about during this time. And we need to teach lots of family support about teaching about signs and symptoms of relapse. They need to understand that this could happen. Like we said, it could happen continuously for years because 2/3 of the kids relapse. Maybe they get their immunizations and, a few days later, they start developing nephrotic syndrome. They're going to get better as long as we can early diagnose them and treat them. They're going to have a good prognosis. But the parents are going to be the one at home with the child. So we need to say, hey, if all of a sudden your child starts gaining weight, their clothes are fitting too tightly, their urine output drops, they seemed fatigued or pallid, they are starting to have some facial edema, or they will even monitor their protein in their urine at home. We need to see you right away because it's, a sign that there's some relapse happening. Complications, we talked about infection. They can develop a peritonitis, a cellulitis, a pneumonia. We worry about circulatory insufficiency, meaning basically we don't have enough cardiac output because we're hypovolemic. And we worry about thromboembolism because, again, if they're hypovolemic, low volume, it just means that the blood is thicker. And when the blood is thicker, it's more likely to clot. Okay. So we're going to contrast that to acute post-streptococcal glomerulonephritis, APSGN. This is the most common post-infectious renal disease in childhood. So after being exposed to strep, again, it usually affects children 6 to 7 years of age, but can affect anybody at any age. It's uncommon less than 2 years of age because most kids under 2 don't get strep throat. Again, it's more common in males, 2 times more common in males. And about 10 days to 21 days after strep infection, or sometimes impetigo, they start developing clinical manifestations. There's a really good prognosis. They rarely develop like renal failure or any long-term issues. But what happens is they have strep throat and they develop these antigen-antibody complexes, and they get deposited into the glomerular basement membrane. When they get deposited in there, then the glomeruli become edematous and get infiltrated with leukocytes. So now the capillary lumen is occluded and we can't filtrate. So we increase our renin production, which causes vasoconstriction, and we start accumulating water and retaining sodium. That's going to expand our plasma and interstitial fluid and cause circulatory congestion and edema. So again, we're going to see things like anorexia, pallor, they're going to appear ill. They're going to be irritable and lethargic. So kind of like our nephrotic syndrome. Older children tend to have non-specific complaints like headache, abdominal pain. Maybe they just complain of some dysuria or vomiting. But because all the fluid volume is staying within the intravascular space, we're not going to have good urine output. So we're going to have decreased urine output, and it is going to be cloudy, smoky, frothy, tea-colored. The blood pressure is going to go up because we have this circulatory congestion, and they're going to have periorbital edema. So they're going to have facial edema in the morning, and this edema will spread during the day to the extremities and to the abdomen. So we diagnose it, we're going to get a UA, and just like with nephrotic syndrome, they're going to have protein. Now, they don't have as much protein as nephrotic syndrome, but they have a large amount of protein. There's no bacteria, so we can rule out like a UTI that's causing the issue. But they're going to have hematuria, which is what makes it different from nephrotic syndrome. And that's because they get this gross discoloration because of the red blood cell and hemoglobin content. And that's what makes it that tea-colored urine. We'll get an ASO titer. That just tells us if they have strep, and then we can treat it. They'll have increased nitrogen, which is azotemia. And this is, again, protein blocks are those building... protein is the building blocks for cells, and they need nitrogen to help kind of build them up. So if there is no protein, that the nitrogen doesn't get used up, so it builds up, and that's why you have increased nitrogen. We're going to get a chest x-ray. That's going to show us if there's any cardiac enlargement because of the fluid overload or pulmonary congestion from the fluid overload, or even a pleural effusion. BUN and creatinine might be elevated, and if they're all uric, meaning they're not urinating, then their potassium level could be higher. So we have to be very careful, because if no P, no K. So if the child's mild, like their blood pressure is within normal limits, they're having kind of urine output that's, every hour or so. So it's, they're controlled, then they can stay at home and be treated. But if they have any substantial edema, hypertension, any gross hematuria, or if they have significant oliguria, then they're going to be hospitalized and kept a closer eye on. We don't do too many dietary restrictions, but we do want a moderate amount of sodium and moderate fluid restriction. So we need to teach them about foods that are going to be high in sodium or potassium, because, again, if they're not peeing, they can't receive potassium. No P, no K. We monitor vital signs like blood pressure because we want to catch things like hypertension early. So we're monitoring blood pressure at least every 4 hours. And we're going to get daily weights and I's and O's because this is the most useful means to assess fluid balance. They can be put on antihypertensives and diuretics to control the hypertension if needed. And they need a lot of bed rest. They get tired very easily. Again, they just don't feel good. So they need those rest periods. And you can tell when they're feeling better, they'll get more active themselves. Kids like to be active. So they're not going to lay in a bed for very long. And we only use antibiotics if they have a rapid strep test that comes back negative. I'm sorry, positive, if it comes back positive. And they have a current strep test or current strep infection. The biggest complication is the cerebral complications. Because of that fluid overload, we want to make sure that fluid isn't getting on the brain. So if they're edematous, if they have hypertension, gross hematuria, we go ahead and put them on seizure precautions and anticonvulsants. And this just compares the glomerulonephritis to the nephrotic syndrome. So you can kind of get an idea of the two. All right, last but not least is Wilms tumor. And this is the most common malignant renal intra-abdominal tumor. It occurs peak age children are diagnosed at 3. Most are diagnosed less than 5 years of age. And it arises from a malignant cluster of cells, usually on the left kidney. So the clinical manifestations are related mostly to the compression of the tumor or the mass. And most children will present with an abdominal swelling or mass. And this is a firm, non-tender, and usually confined to one side, usually the left side. And then they have generalized symptoms like weight loss, anemia, lymphadenopathy, fever. Metastases is rare, although if it is going to metastasize, it's typically to the lungs. They might have hepatosplenomegaly. A hypotension occurs occasionally because of, again, the excess of renin production. Less than 1/4 of cases have hematuria. Most of them just kind of get like fatigue, malaise. They don't feel good. They have this mass and they don't feel good. So we diagnose it by history and physical, but as we're doing our physical, if we suspect Wilms or there's any kind of abdominal mass, do not palpate it until it's ruled out. The tumor is encapsulated, meaning it's self-contained. And if we rupture that self-contained tumor, then cancer cells are going to spread throughout the abdominal lymph node system and through the lymph node system of the whole body. We can get abdominal ultrasound to look at the mass, a CAT scan of the abdomen and or chest. We do the chest because, again, we said metastases are rare, but if they tend to spread, they tend to go to the lungs. An MRI, and because it's cancer-related, they do things like hematological and biochemical studies. They're going to get a UA and they're going to do staging. 90% of those diagnosed with the stage 1 or 2 have a very good prognosis. So treatment, do not palpate, okay? Because we do not want to rupture that encapsulated tumor. They're going to need surgery. Typically, they get surgery within 24 to 48 hours of the diagnosis. We don't wait around. And the chemo will last for all stages. It lasts about 6 to 15 months. So they're on chemo for quite a bit. Sometimes they get radiation, especially if it's a large tumor, if they do have any metastases, if there's any residual post-op disease, or there's an unfavorable history. Pre-op, we need to make sure we're explaining the procedure, the chemo, the risk and benefits, the concerns. Post-op, we need to observe for any intestinal obstruction. The first thing we always do is, with assessments, is our vital signs. So we're going to monitor blood pressure. And then we're going to look at things like urine output, how the infection looks, pulmonary hygiene. We're going to provide lots of family support. Obviously, this is devastating to hear that your child has cancer. And they need to be educated that the child, once well, has to be careful because they only have one kidney now. So they can't do contact sports. Or if they have a GU infection, it needs to be treated right away. Because they can live on one kidney, they can't live on no kidneys. And they need to protect the one they have once the affected one is removed. And that's it. That's Threats to Child Elimination. If you have any questions, don't ever hesitate to reach out and contact me. Thanks and have a great day.